I was looking at the global figures for COVID over the last week. And I just thought that it might help you if you can see the screen, just to look at the overarching WHO report of cases as of the 27th of January. And if you are able easily to see the graph is the week by week, in fact, actually it's scrunched together daily case numbers and the daily reported deaths due to COVID. And the colors divide the cases and the cases between the regions of the World Health Organization. And what I wanted just to show you is, in terms of the global death figures, you can see that if you follow my cursor, in April and then in May last year, there was this rapid increase in mortality. The numbers of cases seems quite small, but that's probably because of lower testing levels. And then the death numbers globally leveled off at around between 5,000 and 7,000 a day. And then progressively, since about November, there's been actually quite a steady day-on-day, week-on-week rise in the numbers of people dying who've had a recent COVID positive test. And the case numbers also showed overall quite a climb. It's not climbing as fast now as it was in November, but it's still overall climbing. We've not actually reached another plateau. And the total case numbers reported to the WHO each day hover between 500,000 and 600,000. That's daily COVID case numbers. And I just wanted to put this up because what this shows me is that the pandemic is still quite strong throughout the world. It's got quite a regional differentiation, but it's so important to hold on to the sort of base piece of information that this COVID is still on the march. And of course, there are lots of different features to what's happening right now that we want to talk about. But I have to keep reminding people there's no evidence at all that this pandemic is anything like over. It's not even slowing down. We might be at a plateau, but we're in no way in a situation where case numbers are actually falling overall. And this is despite the fact that in a lot of regions, quite strong movement restrictions have been put back in place. So I checked up and I thought to myself to find out where is the disease really advancing, and because if you've got big movement restrictions, particularly in Europe, leading to some reduction of case numbers in Europe. And those of you with eagle eyes will see that the green band, which is Europe on this figure, is actually narrowing. And that's because the movement restrictions in Europe are helping to reduce case numbers, but it's still expanding in other regions. And I just thought I'd just give you a few insights that are telling me that things are not right in some parts of the world. Let me start with the good news, and that is that the reports from India and other countries in the subcontinent, South Asia, these are pretty good. I mean, we're not hearing of big climbing numbers from that region. On the graph in front of you, that's the purple. Purple, oops, sorry, I may have messed that up. Sorry for that. The purple is in this figure is the oh, I have to come out of that. So what I was trying to say was that that we have got evidence that in the Indian subcontinent, things are not advancing at a very rapid rate. But I've been hearing from colleagues working in Africa, in different parts of the continent, but particularly in Southern Africa, like Zimbabwe and Malawi, as well as in South Africa itself. And then from colleagues working in West Africa, in Mali, and other countries in that area, Mali, Mauritania, Niger, that they are beginning to see an uptick in COVID, people with COVID in their region, that they're also seeing quite a lot of deaths. In fact, in Zimbabwe, there's been quite a high profile funeral recently because of cabinet ministers dying. And that suggests to me that there are surges occurring now in other places besides the areas that we've traditionally, or in the last few weeks, I should say, been seen as the area where the COVID is greatest. So it's a sort of shift occurring. And you remember, I've always said it's granular and very focal, and you have to be on the lookout for the emergence of what I think is reasonable to call a hotspot. So it looks like there are hotspots emerging in Africa. Other clues, a colleague was telling me that the United Nations is actually having to do medical evacuations for an increasing number of its staff in the Africa region. That again is the sort of indicator that things are not right. And my fellow special envoys for WHO for the COVID response are also telling me that last year the situation in different parts of Africa seemed to be not too serious, whereas right now it looks rather disturbing. So my prediction is that the African continent is going to experience an increasing amount of COVID. Now in India, as I say, the numbers have not really moved up. And I've been asking myself why. One possibility is that in the COVID outbreaks that took place last year, there was a lot of asymptomatic transmission. Certainly, reports from Delhi suggest that there's very high levels of antibody positivity in the population, between 50% and 60%, which is leading some of the Indian epidemiologists to wonder whether India is not having a new surge right now because of quite high levels of population immunity. Let's see. But other countries in the Southeast Asia region of WHO are having challenges, particularly Indonesia, which is in the same region as India. And then as we go further east, reports from Malaysia are not good. So I want to stress that there are, in my view, new hotspots emerging. What's the situation in Europe? Well, I think the UK is demonstrating that their case numbers are coming down, and that I think is very much a result of the movement restrictions that are in the UK, the lockdown. The absolute anxiety that I have, and I'm sure you have, is that because of the impatience to restart economic activity and to help small enterprises in different sectors avoid bankruptcy, there will be a relaxation of the situation in the UK fairly soon, and you can actually perceive in the British newspapers that there's beginning to be quite a tension between those responsible for running the health service, who are pointing out that the system is just really at its extreme with exhausted staff on the one hand, and those who are desperate to get economic life restarted, who often are pushing the British government to take action that is really not the best action in terms of public health. And given that in UK, movement restrictions and lockdown are being used as the primary means for containing the virus, it would be really quite a high-risk strategy, for example, to relax and restart movement before the numbers of cases being reported drop far, far lower than the current 25,000 or so per day that we see in the news. So that's the UK challenge, and it's in other European countries. It's a very acute one for governments because they've chosen to use lockdown as the primary containment strategy. So inevitably, you tighten the screw and reduce movement, and case numbers come down. And then as the numbers come down, you get pressure, obviously, from those who are championing economic activity for really good reasons. I mean, it's absolutely correct. People should be fighting hard to avoid prolonged lockdown. But as soon as you release and movement restarts, especially now we've got more highly transmissible variants in circulation, case numbers will build up. And it's quite uncanny the way in which countries seem to be reaching almost an equilibrium point where they feel that they can keep numbers down, but with incredible restrictions on people's lives. But then it becomes politically impossible, and they have to release, and then the case numbers go up. And we all know that it just doesn't have to be like this, that the use of lockdown as the primary means of controlling COVID transmission is short-sighted. And so I've been asking myself that sort of Einstein question. You know, we've been going on consistently saying that using lockdown as the primary means of control is not clever. And we've been suggesting that the right approach is to do two vital things: to see people as the response, and therefore to invest in people as the primary agents who can prevent transmission through careful behavior. And then secondly, to have a community-based honeycomb of health neighborhood watches and strong public health services that will interrupt transmission through active local level public health work. And we need to perhaps use something different from test, trace, and isolate, because it's got such a bad name, even though I'm so pleased that Nazim wrote a song about it. But what we're really talking about is interrupting transmission. And we need to build into our logic that, as well as people reducing transmission through their behavior, we've got a need for public health capacity at the local level to interrupt transmission, case detection, isolation, contact tracing, and isolation of contacts. And just that activity done on a very wide scale is at the heart of getting, first of all, the current outbreaks down, and secondly, preventing new outbreaks from surging up again. That's the only way that the yo-yo in and out of lockdown can be stopped. But it's hard work. I'm thinking back to something John said in the last series of our briefings. He said very clearly, there's no easy way out of COVID. If you've got a lot of virus in your country, you can't get rid of it just by lockdown. You can't get rid of it by any magic therapy or immunization, that does not get your virus down. The only way you get rid of the virus is by systematically dismantling clusters, systematically containing outbreaks through the basics of infection control, which is to do with case detection and isolation. You can isolate and treat, or you can isolate the people who are well, you just isolate and make sure they don't contact anybody. And getting that through has proved to be impossible. So yesterday, a seminar with an outfit called the Atlantic Council, I was involved in answering the question, why has it proved so hard for Western European countries, for North American countries, to really get on top of this? When Asian countries, particularly East Asian countries, have shown that there is a method that you can use that works. It's not perfect. And by design, you're going to have to continue to be on the watch out. So you will get little outbreaks coming along, and then you'll have to do some pretty rapid and robust response, like we've seen recently in New Zealand. But you've got to get that system in place and make sure that it can work. So why haven't we been able to get this message across to European leaders who have watched their countries go into the most extraordinary recession because they haven't been able to put these basics in place? And they don't even think and talk now about interruption of transmission and breaking up clusters. And so colleagues are saying to me, well, it's because in Western Europe, leaders are worried about their success in the ballot box. And so they want to keep trying to find ways to lessen the pain of people dealing with this. But I can't understand why establishing a basic public health service in the community and doing it well and doing it in a way that involves local authorities who are well equipped to do this kind of work, I don't understand why that could be seen as somehow against liberty or just not in the interests of people. So back to my Einstein question. The definition of insanity is somebody who keeps repeating the same approach to getting a solution, even though it doesn't succeed. And so I'm wondering whether I have to think of a completely different way of getting across the message that the capacity to interrupt transmission is key to getting on top of COVID outbreaks. And so I really value any suggestions that you've got. So are there any other hopes on the horizon for dealing with this massive and growing pandemic? You know, should we be thinking of other approaches? So our colleagues are saying, well, obviously, vaccine. You just increase the population immunity by vaccinating 75%, and then the pandemic will disappear. Well, there's a lot inside that sentence that still remains to be checked out. We don't fully understand what widespread immunization is going to do in this pandemic because it's not been done before. So there's a big experiment underway in the countries that are pushing ahead to try to immunize their adult population and are anticipating completing that task in the next months. It's a big experiment because in all the trials of these vaccines, there was no examination of the extent to which vaccination actually reduces transmission of the virus. The endpoint in the vaccine trials was, does vaccination stop severe disease? And so actually the potential for the pandemic to be contained through immunization is an hypothesis that's being put to the test in the countries that are really moving ahead fast with vaccination. And that includes the UK, which has actually made a strategic choice to go for widespread public immunization, starting with the highest risk groups, but really trying to get up to 70, 75% of the adult population immunized. And they have set also quantitative targets for when they want to do this. And this has now become very politicized. But yeah, the UK is one experiment, and Israel is the other experiment. I mean, the Israel experiment, just so you know, it's pretty much using the Pfizer-BioNTech vaccine, that's the synthetic one. They have managed to collect quite good data on responses to Pfizer-BioNTech after one dose, and then responses after 2 doses. And everybody will watch Israel very closely to see how long the protection lasts for, how quickly infection rates come down. But I think the British experiment is interesting because it's a larger population, and the mainstay of the British immunization, I think, will be the AstraZeneca Oxford vaccine in the coming weeks, although up till now it's mostly been Pfizer and BioNTech. But the point that I've said before, and I think has been really strongly said this week by many commentators in the UK, in Europe, and globally, is that if a small number of countries decide that they want to march ahead with immunizing all their adult population as quickly as possible, and they're scouring the world and doing deals to get vaccine, despite the fact that there are really, really serious supply problems in some of the plants, in brackets, supply problems that are perfectly normal when developing vaccines. It's a common thing that lines have to stop because you get contamination, close brackets. But the British and Israeli, and to some extent US, focus on really getting a lot of people vaccinated, which is also encouraging through competition, excitement in Europe and excitement in Latin America and in other parts of the world. This sort of sense that the potency of a country is reflected in the proportion of its people who can be vaccinated as quickly as possible is having some really interesting and acute impacts. And I think these impacts will change the world. Firstly, we just have to think of the biology. Right now, because there's so much virus in the world, with somewhere in the region of 600,000 people newly infected each day, the opportunity for mutations to occur is huge. And then the possibility of that very rare phenomenon of a viable mutant emerging that has different properties to the original virus is just massively increased. There's so much virus around, so much. I mean, I couldn't even venture to suggest the number of virus organisms for COVID that there are currently in human beings in the world today. But it is massive. It is orders of magnitude greater than it was a year ago. And so it's inevitable that there is an increased likelihood of a mutation emerging that is capable of being more easily transmitted, causing more severe disease, or evading the antibodies that are produced as a result of one or more of the vaccines currently available. It's called immune escape phenomenon. It's got other words as well. But that's the reality, that there will be immune escape at some point is increasingly being stated by virologists. And those same virologists are saying, if you want to increase the likelihood of immune escape, theoretically at least, that likelihood is increased if by any chance people have a feeble antibody response to the vaccine, because that means the virus can break through, and that creates a selective environment that encourages the emergence of resistant variants. It's a little bit like with antibiotic resistance, and you might know this. If you don't take a full course of antibiotics, you end up with a low level of antibiotics in your bloodstream, and that favors the emergence of resistant bacteria that can beat the antibiotics. So we've always said, be super careful when you've got declining levels of protection in someone's body. So, for example, if there's an awful lot of people that only receive one dose of a vaccine, they will have a partial immune response. And actually, they are sometimes rather well placed to become the incubator for the kinds of variants of the virus that can cause additional difficulty. So there is a group of virologists who are saying, if you really want to lessen the risk of immune escape, don't go around and offer people a long interval between their vaccine shots, say 12 weeks, because that might create an increased likelihood of resistant virus variants emerging. So this is leading to intense debate about some countries with their strategy of having a prolonged dose and a certain amount of spatting between various places. Now, when we come to the vaccines, only one of the currently available vaccine has been through the WHO process for checking it and for doing an emergency use authorization. That is the Pfizer-BioNTech vaccine. The Moderna vaccine is in process. AstraZeneca vaccine, WHO has not received the data. Sinopharm vaccine, WHO has the data and they are being studied. Sputnik 5 vaccine, WHO has not received the data. Yet, because of the vaccine rush that is going on, there are now vaccines being traded across the world that have not gone through phase 3 trials completely, that have not been given emergency use authorizations, but they are being marketed and used. And you probably have seen in the papers, we've got information about vaccines going from Russia to Argentina, from China to various countries, particularly in Africa, and from India to Nepal, Bangladesh, and so on. And these are vaccines that have not got their emergency use authorizations. Now, a national government's perfectly at liberty, of course, to say we're going to use a vaccine and we're going to license it ourselves. And they can also adapt it. So Germany, it is reported yesterday, said we're not ready to authorize the use of the AstraZeneca Oxford vaccine in people over 65. Furious reaction from certain quarters, but that was what was said, because the clinical trial data for the AstraZeneca Oxford vaccine is a bit light on how it performed in people over 65. I tell you that this vaccine rush, the use of vaccines that are not authorized, and some of the, what I understand to be panic buying, is not good. You know, I just read today that the Palestinian Authority needs vaccines. So what they've ordered 100,000 doses of Sputnik 5. They'll get 10,000 free and they have to pay for the other 90,000. This Palestinian Authority is bankrupt. I know. What on earth's going on? You know, we have an aid system in this world. We have vast institutions that look after communities suffering hardship. And I don't understand it. Never, ever seen a situation quite as peculiar as we're in at the moment. And I'm not the only one. So Tedros and team at the WHO over the last 2 weeks have got more and more strident about the breakdown in the system. They created, at the request of governments, something called COVAX, which could work. But it can't work if countries do private deals with vaccine manufacturers, don't talk about the delivery conditions, don't talk about the prices, it's all secret, and seem to be working round the back of the very transparent COVAX scheme that WHO, Gavi and CEPI set up at the request of government. So governments having asked for this scheme, which is there, ready to go, all with the proper things in place. Okay, so the vaccines might start 2 months later because the WHO authorization process is super rigorous. But the same countries that set this scheme up are systematically undermining it and creating a situation in which unproven vaccines that have not got authorizations are being sought after and then used in countries that do not have, I believe, the necessary capacity to actually set limits on what kind of immunizations are used. And with this constant production of variants that can escape from vaccines, and the likelihood that variants will react differently in people who've received different vaccines. So we're going to have very, very different situations in different places depending on what vaccines are used. Just create, at least for me, the potential of a really, really complicated situation in the coming weeks and months. And the only way to deal with it, Tedros, Mike Ryan, others make this point, the only way to deal with it is with a measure of centralized control over surveillance, over vaccine authorization, over vaccine distribution, and follow-up monitoring of those who are vaccinated to see what happens to them. This is a giant biological experiment underway, and it ought to be properly controlled. It ought to be properly organized. So I'm not going to, in my work on COVID over the coming weeks, I'm going to focus on this relentlessly, trying to re-establish some degree of global management of the immunization process. Thank you. Now, Twee, if I could go over to you, I'd love you to give us stuff, and then I've started looking at my messages, and we'll start the conversation. Twee, please.
Thank you, David. So as a little pause, as David looks at some of the questions that have come through, we get to do a little bit of a poll. So I'm launching that now. You'll see that on your screen. So I'll read through. As I read through, please do answer as we go along, and then I'll be able to share the results afterwards. It is anonymous. So the first question is, what is Dr. Edward Jenner, an English physician and scientist, most recognized for? Option 1, discovering penicillin. Option 2, pioneering the concept of vaccines. Option 3, inventing the microscope. Question 2, the first modern public health treaty was negotiated under the auspices of the World Health Organization. What was it about? Option A, tobacco control. 2, breast milk substitutes, or 3, universal health care. And then the last question is one which I actually didn't set up correctly last week, and I'm redoing it now and have actually missed a word, but which of the following have you experienced? So you can select multiple answers here. So 1 is a COVID test. 2 is if you've been part of contact tracing via an application or a call. If you've had to isolate because of probable exposure to COVID-19. Option 4 is where I've missed the word. This is COVID-19 vaccine. If you've had the COVID-19 vaccine, please select that option there. And then here's the one I missed last week, none of the above. Are you seeing this poll? Yes?
Did at the beginning, it's gone now. Oh, I think because I filled it in. Oh, yeah.
Okay.
It appears when you fill it in.
And I think while we wait for you to answer, I'm just going to spotlight Chris's illustration so we see how that is coming along. Fantastic.
So we got Boris in there. Apologies.
Thank you very much indeed. I like your sort of political angling of these pictures. They're lovely.
I've prepared an enormous rant in response to your questions, but I think it's probably better for everyone if I don't deliver it.
Well done.
Thank you. All right, so I will end that poll, and I can't see the results actually, but I can give you the answers. So the answer to question 1, Dr. Edward Jenner actually was, the answer is option B. He pioneered the concept of vaccines, and he did this by looking at people who had contracted cowpox, and they were less likely to get smallpox. And so there's a slightly unethical story there about how we went about finding that out, but interesting nonetheless, and that is where the word vaccines comes from. Variole vacinae or vaccinae is the name of cowpox. For number 2, the first modern public health treaty was on tobacco control. So that was adopted in 2003 by the member states of the World Health Organization. And to date, there are only 15 states that are non-party to the agreement, but the rest of the 194 member states of WHO are party to that agreement that govern the production, sales, distribution, advertising of tobacco. And then number 3, I cannot see these results, but I think I'll have to look at them after the session and share those with you on the LinkedIn chat.
I can see them, Twee.
Yeah.
So the COVID-19 test is 52%, just over 52%. So about half of us have had a COVID test. The one we didn't see last time is none of the above, which is about 40%. And remember that people can answer multiple questions. So vaccine, 13%. Isolation due to probable exposure, about 1 in 10 of us have been through that. But only 4 of us have been picked up by contact tracing, interestingly, either by an app or a call. So those are the numbers, too.
Thank you, Jan. Back to you, David. For,
Brilliant. Everybody, if I don't advocate relying on vaccination to control the pandemic, which at the moment is just not on because there's so little vaccine available and it's difficult to administer, what are we talking about instead? We're talking about having capacity to encourage more and more people just to distance, to mask, to isolate when sick, to do good hygiene, and really a rapid build-up of local level public health capacity. We need that for identification of cases, and we need it also for the vaccination. John, just for a second or two, no, a minute or two, could you talk a little bit about the work you've been doing recently on the local level? Could you discuss a bit with Annie, if you feel like it, who's written some comments in the chat about why on earth track and trace is not working, how to speed up local level capacity to bust clusters and interrupt transmission?
So we had a little look at because I'm UK based, on the English approach to vaccination, and wondered what it might learn from our approach to test and trace, or track and trace, test and trace. And in a way, it's sort of a little disconcerting that we appear not to be learning the major lessons. You remember, those who heard me speak on this earlier here, that one of the things with test and trace is it sort of it focused on the activity, but maybe missed some of the point. And the point, as David has been saying, is to interrupt transmission, because it's fine to test lots of people and to a lesser extent manage to trace their contacts. But if they're not isolating at the end point of that, and there's good evidence that in England at least, compliance with that is not as high as it could be, then the process isn't getting to where it needs to. And what happened with that is that we found that people who couldn't afford to isolate, who we weren't giving the support to, obviously had to carry on working for basic income. And we ended up with some quite deep pockets of infection in some of the poorer parts of our cities. Well, what happens if you run a national vaccination program by targeting it by age group? On one level, it's a really, really sensible thing to do, because people are more vulnerable, obviously, as we've seen in older ages. But what happens also is it's not okay to say, well, we hit 85% of the over 80s or whatever, if the 15% that we haven't found are in the same areas of our cities and our towns and our countryside as we weren't reaching before with test and trace. And national programs can't get to these groups of people who we find harder to reach that easily. They don't have the connections, they don't communicate in ways that make sense to them. And so the risk is we continue to exacerbate deep and lasting areas of infection where people are just having to continue to work, not getting vaccination in the age groups that you might hope. And therefore you build that risk of exactly what David was saying, of areas where potentially the likelihood of strains mutating increases. So if we're going to do this and do this right, this old adage that we're not safe till we're all safe is true. You know, we hear stories of people rushing to see if they can get to the top of the queue, if they can buy up old vaccines that have not been taken out the trays. That element, that sort of approach still is going to leave people unsafe, and that means that we're all unsafe. And therefore, the key to that is, how do we connect across all sorts of levels of governance? So whether it's global, to make sure that countries, as David's been talking about with the Palestinian Authority, that we make sure that there is an equitable distribution globally, that it's true nationally, that you need to connect national to local, the local levels of governance, and you need to connect that down to community levels of governance. And where that happens, we see markedly different outcomes to where it doesn't. So if you look across the patchwork of English cities, you will see some where, despite having high levels of the new variant that's more infectious, the infection rates stay lower than in areas that are perhaps struggling to get those connections to work. So that's something that we've looked at over time. With David spoken about the honeycomb of relationships in a place. It's important that that honeycomb connects to each tier of governance, so that each area, each level can do those things that it does best. National does big volumes in quick time, but it misses the people we perhaps most need to get to. And I've put a little note in the chat to a link of where David and I published some of that for the Municipal Journal, a local authority a publication in England. But it also connects, I think, to some things Annie was saying. So I wondered, Annie, if you'd like to sort of follow in on some of that, particularly perhaps about what happens at the local community end of things and how we're doing there.
And after Annie, I'd like to see if Shamim can can make a couple of inputs from Bangladesh. If you've got a good connection, I heard you just now. So just teeing you up. Over to Annie.
Thanks, John. Thanks, David. Yeah, in some way, I'm more hopeful about the local action which can address the sizable pockets of our country where there is a suspicion about the vaccines and where that historically has come from. And so we are already, I think, mobilising amongst the BAME, the Black and Asian and minority ethnic communities, to actually see whether we can look at some of these resistances to vaccines. Going back to what David was talking about, yes, we are in the UK depending on the vaccine. And I think the reason why, in some sense, we're stuck with that is all of the public health developments that other sort of more rational alternatives require hit again at the slow capacity building of state structures and the inequality in England. It's this lack of, it's the inequity, it's the small state ideologies, which means we're just not doing it. So in a sense, I suppose I'm really hoping for a message which says, you know, relying on vaccines may to some extent work. I hope it is, because it's taking us such a long time to build up and recover from the awful underinvestment of our social services and health service over a period of decades. And I'm hoping that we don't lose the vaccines, I suppose, because I'm not sure what else there is in the short run.
So me too. And thank you for stressing. This is truly a result of just continuous underinvestment and what we call cheese paring, cutting off. Thank you, Ken.
Yeah, I agree with that. I agree with that.
Thank you. And Shamin, I mean, my own judgment is that in your country, the connection between local government and central government is actually probably a lot better than it is in Britain. But I am nervous about the sort of vaccine enterprise, vaccine competition that's going on, and wonder how you react to this.
David, thank you. My feelings is that, when people, know about the vaccine progress, people are very positive and they wanted to have the vaccine, but the process we followed to, recognize the different vaccine status, quality, and social media and other media give the information to the people, that become a little bit complicated. And the procedure we followed, like giving the legal status for doing the vaccine trial in our country. First, we found that China government, wanted to do the vaccine trial in Bangladesh. Two big companies, institution from China, they applied to do the vaccine trial. ICDDRB and other, CRO were involved in that process, but finally they did not get the approval for do the vaccine trial in our country. On the other hand, the government, made a very good judgment to get the vaccine at the first stage. They made contract with AstraZeneca from India, and one private company, Beximco, they took the responsibility to make the contract, and vaccine they ensured to have it in our country. But the whole process we followed, and media played the role. There is a very low trust about the vaccine among the people. However, I feel that it is my personal understanding that the role of WHO and UN was very limited, that people had some sort of more expectation from UN organization and WHO regarding this vaccine politics. I feel that the role was little bit limited, and my understanding is that they should play more role to make trust people on the vaccine, because we are hearing that COVAX is now on board and it is coming up. So this is important from my perspective.
Yeah. Thank you very much indeed, Shamin. Gosh, when I hear that about that interplay between different companies and government institutions from China and the International Center for Diarrheal Disease Research, you can see how delicate these things are. Goodness me. Thank you also for your comments about the role of of the WHO. I think all of us who work inside the system feel that we could be doing a lot better, and I shall take those words with me. You know, we've maintained a fairly steady rhythm of communication 3 times a week, major briefings and so on. But one could say that right now, the need for very, very clear communication is so massive with all the sort of vaccine politics underway that one perhaps ought to say, well, now more than ever, you need a real surge of communication capacity just to really level with people about what's going on. So I shall thank you, Shamin.
Thank you.
Thank you, sir. James Ritchie has joined from New Zealand, and I think you're still in New Zealand, but I might be wrong. Yeah, there you are, and I think you're both there. And you have to tell us where you are, and just you've been doing this amazing campaign on behalf of workers in the food sector, particularly in meat plants, through the International Union of Food Workers. And actually, I think that's one of the most beautiful and delightful success stories of this whole thing. I mean, it's not perfect, but according to my studies, you have seen a change in working conditions, which may be the long-term benefit of the often really disadvantaged workers in this sector. Over to you, James.
Well, thank you very much, David, and good evening, everybody from New Zealand. I know it's good morning in many places, or good afternoon, but it's good evening here. We're very much enjoying our life here in New Zealand, which is pretty free at the moment to be able to go around and go about our business and see friends and family. In terms of the situation in New Zealand, we know how privileged we are, and we're super privileged. There's been good work, there's been very good leadership. And if you don't mind, David, I might just pass over to my wife, Jane. Jane Lawrence.
It's lovely to see Jane. I saw Jane, she's in the bottom corner, but it's lovely to see you. Welcome.
Who is actually doing some work now with the Ministry of Health on protecting the border here in New Zealand. So, Jane, you might want to comment on what you've seen.
Yeah, sure. Thanks, David. Yes, it's a little bit tricky because, you know, being in a country that's privileged at the moment, it's almost like you almost feel like you don't want to speak up because you don't want to feel like you're showing off. But I think it's important to show that alternatives are possible to what's happening. And I was noting, David, when you were talking about, you know, your question about why can't we get around this, you know, with the sort of surge and retreat mentality. But I would comment that when we had the last outbreak in New Zealand, which was actually quite tiny by international standards in Auckland, it really tested our capabilities for test and trace to our maximum. So it's almost like the lockdowns give a transmission shock, which puts you in the position that you actually have the capabilities to find the perimeter of clusters. And so it's almost like you have to get to the point where you can put those strategies into action. So at the moment, we've had a single case in the last week of community transmission. It was a case who came out of our managed isolation and actually we think contracted COVID in there from another returnee and then took it into the community. We've been extraordinarily lucky that it hasn't resulted in any, we think, in any kind of onward transmission. But, you know, we've got this machinery now that launches into action at the slightest hint that something's going on. But you actually have to be in a position to be able to do that at scale. So that would be my comment on that, is you have to be you have to get to the point where that can work. I think the other thing I would like to comment on is the vaccination and the global ethics of it. Our Minister for COVID, we have such a person, a Minister for COVID in New Zealand, was on the national airwaves last night talking about the reason that New Zealand's actually delaying its program. We're not even beginning to start till March, and that will be our border workers and then our vulnerable and moving on. New Zealand's made the principled decision that we don't need it right now as much as others. Now, this is a gamble because at any moment we could have a breach in our border and be in a really awful position. But they're saying we are not the priority. And we've also, as a country, put aside a reasonable number of millions of dollars to protect our Pacific country neighbours. And I think that the more that the world can take those positions, as you say, the better we're all going to be in the medium to long term. Thanks, David.
Jane, that is just so, so wonderful. You want to send just masses of appreciation to your leadership for just having the courage to be human and to think it through and think what it means instead of this alternative that we're seeing in so many other countries right now. Thank you, Jane. Now, Molly Melching, are you still on? I'm looking, and I don't think.
The other one,
Are you on one?
Here I am.
Come in. You be the last one before we go to Chris. We're going to go to Chris, of course, because I have to give Chris a really good opportunity to let off steam. But Molly, come in, please. Tell us where you are.
I'm still in Senegal. I live in Senegal,
Yeah.
where cases have increased greatly. We were going through a period where we had very little cases and everyone was so optimistic and they let down their defenses. And so now we're having lots of outbreaks that we, think are not always recorded. But it's pretty serious. And we're talking about the last communique that the president put out was on the 26th, and calling it a catastrophe. So, it's worrisome and we don't have vaccines here. It's a very dire situation. I get pictures, people are sending in, cemeteries that are filling with people where they had 3 people a day, they have now 20. It's scary. It's a scary situation.
Molly, thank you so much for telling me. This is exactly, just like I told you that there's an increase in UN medical evacuations from several African countries. We're hearing, and it's come through on the chat, bishops from one African country that's a COVID denier saying there is a serious problem building up. And now you, Molly, are telling us that there's some stuff happening in cemeteries.
Oh, I can send you an email or a WhatsApp with in Tuba, where we thought things were, people were saying it's, mystical, that there were prayers and everything. And now I will send you the cemeteries with people coming in and the rows and rows of new tombs. If you send me a place to send it, I will send it to you because it was a bit shocking for everyone to see that. It sort of woke people up. And then we started hearing from other cemeteries where people are waiting in lines to bury the dead.
That's how we knew that stuff was really bad in Monrovia during the Ebola crisis. We had overload in the cemeteries, had to start cremation, which was a really, really awful thing for Liberians. And then, in a way, that was the trigger. At Spikers, we are going to Chris Shipton. We've run out of time, but I think you're making faces.
Can I just say, please look at the brochures on the coronavirus. We're getting so many requests for them.
Oh, brilliant.
Because they're very colorful and adapted to African villages. And I put it on there. I put the.
Thank you, Molly. And I want to receive the WhatsApp, if you don't mind. Ad Spikers, are you trying to check? Yeah, and then.
Very briefly,
very
David.
Brief, yeah.
Thank you very much for your detailed briefing again this morning.
Yeah.
We worked in the UN country teams in several countries, and I'm really pleased by the remark of the colleague of Bangladesh.
Yeah.
In many countries in the global south, I believe that UN country teams can play a much more active role. And taking some experience of the fight against AI 10 years back, here is a role, I think, to make a connection with governments and with development partners. Secondly, David, I sent you a note on this technology access pool of the WHO. This is not tomorrow, but on medium long term, I think developing countries should be in the possibility also to have technologies to produce their own vaccines. keep that in mind also in the further negotiations.
I agree, and thank you for that. Magen Motefa in Gaborone in Botswana reports what we're hearing from others in Zimbabwe. Come on, Magen, just say it quickly because we need to hear these words. Can you talk?
Yeah, part of my family is in Zimbabwe, and they're no longer transporting bodies to the villages. If you die in Harare, you get buried in Harare because the undertakers can't cope. They can't drive bodies because people are dying in droves. So it's actually dire, and doctors are also on strike because they've no PPE and they've lost 4 doctors, I think, this week. So it's actually, the situation is dire in Zim.
So sorry.
So I don't know.
So sorry. I have a Zimbabwean colleague, and yesterday she was telling me about all these cabinet ministers having to be buried in a funeral. She just said it's really difficult, and the health system is just completely overwhelmed.
Yeah, and there is no testing. They've only tested about 1,000 people. And these were people who were traveling. Otherwise, there's no testing whatsoever. So they realize people have died from COVID after postmortems. So it's really bad.
Listen, everybody, this has not finished. And we have to help everybody understand this is global, and it's going to go on causing suffering, particularly in poor places. And they have very much less capacity to cope than in Britain or in the US or in Eastern Europe.
Yeah.
This needs some work. Magen, thank you. Stay in touch. We are with you. Solidarity matters at this time. Please don't hesitate to send us texts or emails. Chris Shipton, please. Let's light up your picture. Yeah. Tell us what's happening.
Oh, well, all I can say is that I've written Anarchy in the UK, which was my words, next to John Bull and the Bulldog, who are a sort of favourite visual go-to whenever sort of the topic of British nationalism comes up, which it sort of did. And I think, the thing that I've been sort of worrying about a lot is, the political rhetoric that exists, I think, in Northern Europe to possibly answer your earlier question, which is essentially this kind of belief that we're all going to go snap back to reality and everything's going to be completely normal and this is just a blip. And there's sort of modern historians who are saying we're going to look at the world as sort of BC and AC, as in before COVID and after COVID. And I think the really hard leap intellectually or whatever is, are we ever going to go back to the world like it was before? And especially on a miserable locked-in winter in Britain, feels like that might not happen.
So right at the bottom, you should write, is there a return to normal on the cards or something like that? Because I think that's the big question for everybody. But we could take advantage of this and make the new normal perhaps even better, even more equitable, even fairer than the old.
That's because the answer to all of this, the answer to those questions does seem to be, public health is a sort of, something where you actually have to invest and...
You have to invest, and it's hard work. It's hard work. It takes ages to build up a good public health system. Chris, thank you for sparing your time to join us. We really, really appreciate your interpretation of what we say. We love it. And this is an absolutely majestic one as far as I'm concerned. Some things that if I were in editorial control, I would say, like vaccine hysteria, but these are your words. And I love it.
Do let me know if there's anything too untoward in there and I can edit it.
If you don't give space to artists to put what they think, then what's the point? No, this is your moment. Thank you very much, Chris. Everybody, thank you for joining. It's absolute, total joy for us to be connected with you. And we're finding this present moment quite challenging. And it's through being with you and hearing from you, it helps us, particularly when it comes to the positioning that we're trying to do. And there's been a lot of suggestions that you've given us. So with that, the team says, and I say, bye-bye. We'll be on next week in the evening time if you want to join. And do always send suggestions through the WhatsApp group if you've got any comments. Thanks to Twee, thanks to Catherine, thanks to John, thanks to everybody who's been behind the scenes, sending me lots of lovely texts to help me navigate my way through this. But most of all, thanks to you. Thanks to you. You are brilliant. Bye-bye.